Please join me in a warm welcome for Alexandr. Thank you.
So, thanks a lot for this lovely introduction, and I'm really happy to be here and try to tell you what we do in Germany. And you will see that a lot of the things I will talk about you already also heard in some of the talks before today. So things like the triple aim, I'm happy it was already explained. I will also show you things like that, cultural issues and all these things. But just let's go into detail. So I will talk mostly about the model Gesundes Kinzigtal in Germany and how taking accountability for a whole region and for the health of this whole region is our job there. So where did we start? We started with a problem in Germany. The German healthcare system is really fragmented and it's designed for repair. It's really good to fix you up and treat acute diseases. But, and that's a problem I think most of Western countries are facing right now, it's with the rise of chronic diseases, it's not really good for that. And it's not good to keep people healthy and to maintain their health and to bring innovations into the system. And in this system, patients are lost. You read in the newspapers that doctors get more burned out there, and the long-term affordability is in question. So what we thought is, how do you design a healthcare system that's high-performing and where you can work against this? So how can we do better and innovate a healthcare system that's more efficient and that produces health? And for that, we looked at the triple aim. And interesting thing is that we already started in 2005. The triple aim came out in 2008, but we thought that's exactly what we are doing and what we want to achieve. So just to bring the 3 points again to you, it's improve the health of the population, enhance the patient experience, and doing this in a cost-efficient way. And we achieved this vision in our model Gesundes Kinzigtal. So the participants there, they are living longer than a control group we evaluated. There is positive evidence also confirmed on multiple quality indicators by an external scientific evaluation. We had an evaluation for the years 2004 to 2011, and we now got financed a second round so that in the end we will have 10 years of evaluation, of external evaluation. So it was also important for us that not we, as the company who is running it, is evaluating it, but an external scientific institution. Also, the patient experience, this is out of a survey that was done there, also by external evaluation, shows high satisfaction of the patients with the system. And all in all, we saved since 2007 about 36 million euro in gross savings and about 11 million in net savings there. And it produces value even in 3 more dimensions. One is the quality of life and the professional satisfaction there of the providers. We already heard that this is sometimes also called the quadruple aim. And it secures the healthcare in this region. So this is a rural region in Germany, and the physicians there, the outpatient physicians, the GPs, they already have problems to find colleagues who will take over their practice. And with this model we implemented there, we were able to bring new colleagues into this region that took over their practices and are now also part of the model. And last but not least, also it produces a healthy workforce that's important for the companies that are situated in this region. So what are, in our opinion, the success factors that made it possible to achieve this? So the first thing was a long-term shared savings contract for a geographically defined population. These are a lot of words, and I'll show you what it means. First thing is, the contract we made in Germany with payers were for 10 years. Because we said if we want to invest in prevention and in health promotion, it will take time to get the results. And if we motivate all the providers there, if we put our effort in it, we also want to profit from it in the long term when you see the big results. And it makes also sense because from an economic standpoint, you can't invest in things where you will have a return on investment in 6 or 7 years if you have only a contract for 2 years. And it was a shared savings contract, which means that we are accountable there for the whole region, for the insurees of the 2 healthcare insurance companies where we have the contract with. So in Germany, you have a competition between healthcare insurance companies, and we have a contract with 2 of the insurance companies there, and this is about 50% of the total population of this region. And we also said we want to define this shared savings contract on a region so that we really have an incentive to focus on the people that need a better care the most. So we have no chance to make a selection of patients there. We can't choose the providers, we can't choose the patients we want to have in our model. We have to deal with everyone who is there and because he's automatically in our shared savings model. And it works pretty easy. So all you need is just a national benchmark that is risk adjusted, of course, to your population. And then if you achieve to lower your total costs in comparison to this benchmark, then you have shared savings, and you can use these shared savings to invest in quality and efficiency and produce even more savings. And so you have like an engine that's running your investments into better health and better care. And to succeed, you also need an entity who's running that. You need a regional integrator. And this integrator, I will show you how it is placed in the German healthcare system. So I will give you a short overview about how the healthcare system in Germany is working. So you have on the one side, you have the population there who is paying premiums to a national risk adjustment scheme. And through the national risk adjustment scheme, the insurance companies in Germany get so-called RSA locations, which means they get risk-adjusted allocations for their patients. This is because we have this competition in Germany between the insurance companies, and they should not compete for the healthy, rich people, but they should compete for better quality and better costs. So that's why they don't get the money directly from the insurees, but they get it risk adjusted from this national risk adjustment scheme. And then they pay the providers, the hospitals, the outpatient care, and all kind of other providers. And the providers, of course, they bring the services to the patients. So in this system, you have the problem that you have a lot of mistrust in the system. And it's that, if I put it in simple words, the statutory health insurance, they only want to cut costs and want to lower the prices for the providers. The providers want to bring as much services as possible to the patients because they are paid mostly on volume. And the patients are happy to get as much as they can get, in easy words. So what we said is we need a regional integrator who is sitting next to it and who is intermediating between these interests. And this organization is owned 1/3 by us, a management company for such integrated care contracts, and 2/3 by the MQNK, which is a local physician network. And they own 2/3 of the company, which means we wanted an incentive for them to think beyond their practice, think beyond what they are doing just there, and think about population health and about efficiency. And we do additional investments in things where we think they will improve the care, And we then refinance it with this shared savings contract with the insurers. And as you see, we didn't change the whole remuneration system at first. We're now doing a little bit of that. So starting this year, we now remunerate our physicians directly with a budget we get. But in the beginning, we didn't do it because we wanted to focus our providers on the improvement of care. And we didn't want to talk the first 2 years with them just about how much money are we getting in the new system and what's better or worse than the last system. We wanted to focus them on quality. Then another thing you already heard today, get the patient on board, and I mean literally on board. So we have a patient advisory board that helps us to decide which kind of services we want to bring to this. We have an ombudsman, we have our own patient rights charter, and it all makes sense because if you achieve a higher activation of patients, you will also achieve better results on the costs. Then we needed investment to start all that because we really implemented a new company there with new services. Because out of the usual, the physician couldn't do it in his own practice, or the hospital also couldn't do it just in the budget it has for its hospital. So we needed investment. And we got, in the Kinsichtal model, about 4 million for the start. It was a government subsidized investment, and we now have a second model in Hamburg where we also got about 6 million to get this running. And you need this investment, and in our calculations, it's about 3 years until you reach break even, and you can then finance everything out of the shared savings. Another thing is important to focus on the culture of quality, freedom, mutual responsibility, trust, and innovation. And maybe that's a little bit different to at least what I have seen in the US and with accountable care organizations there, because they try to get as big as possible, as fast as possible. And what I think is, yes, you need some scale to get efficiencies, but when you get scale, you still need smaller entities who are running these things on a regional level. Because you need the trust of these physicians. They must feel responsible for the other person. They must meet on the marketplace, in the supermarket, and talk to each other. And if you have 1,000 physicians, they don't feel responsible anymore. They just are one anonym person in this huge mass of physicians. So that's why we think it must be these regional entities that are managing these must be smaller. And you need a mixed top-down, bottom-up approach. So evidence-based approaches combined with locally adapted interventions. And they also have to go beyond healthcare. And with going beyond healthcare, I mean, of course, we did the usual that everybody knows you should do, things like focusing on primary prevention, health programs for chronic diseases like heart failure, back pain, psychic crisis, depressions, and things like that. We also worked on quality indicators, and we implemented an own health training and fitness facility there. But we also included a lot of organizations that are not in the primary or not primary healthcare organizations. So going to things like schools, like employers, to going to the communities, to the mayors there, and bringing this topic really there. And with that, I also come to another important point. It's the comprehensive implementation of technology. And with that, I mean especially 3 factors. So we implemented an electronic health record where all the data are shared between the providers. And we did it there 10 years ago because we already thought back then that in the whole of Germany, we won't have an electronic health record in the next years. And it was true. So we still have no electronic health record in Germany as a whole. And maybe just one point here that was also interesting for us. This thing also needs, again, a cultural change, because at first, when we implemented it, every one of the doctors, we got them on board. They said, yes, we will do it. But then when we started and they realized, oh, the other doctor is really seeing what I'm doing, we got a backlash. And they didn't use it as we wanted them to use it. So we had to really work with them and, again, build the trust so they also use it. Same is with the business intelligence solution we implemented. So we implemented a big data warehouse where we use all kind of claims data to make quality reports for our physicians and work with them. And also this took time and took trust to really work with this data. And last but not least, there were also e-care applications and services we worked with, like telemonitoring projects and things like ambient assisted living technologies were implemented, and also working now with apps and mobile tracking devices to bring also these data back and use it to improve the care. And just to give you a little glimpse, this is one of our dashboards our physicians get, and where they can see structure, process, and outcome indicators, where they have benchmarks to their colleagues, and where they also can drill down and really see which kind of for example, inadequate medication did I give. They can drill down to patient stories and see why they are shining up as bad outcome in this report. So really getting down into the details with them. But also here, if you just send them, or this is on an online platform where they can get into it, if you just send it to them, they are not using it. You really have to work with it, and you have to go through it in all kind of different ways. So we use quality circles, we use one-on-one discussions with the project manager in the region. We have peer reviews where they're going from practice to practice, discussing these numbers, because otherwise, if you just send it out, it won't get used. So, and is it so special that you can't do it in other regions? I think no, and we now have one in Hamburg where we started it last year, and we are also spreading it now we have a joint venture already in the Netherlands and in the UK, and are negotiating it in Belgium, because the underlying problems are the same, and this approach to go to more accountability is really something that you can see in Europe, that you can see also around the world, and where you also can see it a lot, and you heard it before in the US, where these accountable care organizations that were allowed in 2010 really got a big rise over time. So I think this is a trend that you really have to look out for, because it just makes sense to more look on the value that is produced and not just only on the volume that providers can sell. So, and last, what are, in my opinion, implications for the development of hospitals? So one analysis we did is, if a model like Kinzigtal would be implemented in the whole of Germany, then about 1 billion hospitalizations, 1 million hospitalizations could be avoided. So this is an analysis about so-called ambulatory care-sensitive hospitalizations, which means hospitalizations that could be avoided if the outpatient system is structured in a really good way. So you see, in our model, hospitals have to change in the long run, because if they just do the business model as usual, they will lose. And we are currently working with the one hospital group that is situated in the Kinzigtal area, and working with them on a sub-budget or a sub-shared savings contract. So they then will also profit if shared savings are achieved. So we just take out their costs and compare it to a risk-adjusted hospital costs of other providers. And then, if shared savings are achieved, they will get something out of that. So they then can think about how can I restructure in this new kind of way and can still make a profit, but with lower volume. And we also try to bring this in a broader perspective. So we just recently took over the management of the German network of health-promoting hospitals, and also try now, from the hospital perspective, bring these ideas to hospitals in Germany, and with them thinking more about what value can we produce and what new role can a hospital have in these account care organizations. And I'm speaking here as an organization where we, in the first model, started mostly from the outpatient provider side, so 2/3 are owned by outpatient providers. In Hamburg, we now, in the second model, we also have hospitals on board. And initially, when we thought about this model, we wanted to do it out of hospitals because they have the structure and they already have the more possibilities and resources. And if you look to other countries like the US, a lot of these organizations are coming out of hospitals. So you can do it from both ways. Yes, and with that, I want to finish and I open to questions.